Surgical management preoperative planning. All studies, including esophagram, esophagogastroduodenoscopy, EGD, manometry, and pH testing should be readily available and reviewed prior to and at the time of surgery. The esophagram should be displayed on a spare or dedicated monitor in the operating theatre, and EGD images be loaded as well for intraoperative reference. Attention to fine detail of the manometric report may avoid an unnecessary and detrimental 360-degree fundoplication, as a complete wrap may worsen symptoms in the light of the following findings: severe esophageal dysmotility. Figure 2. Anatomy of fundoplication failure, including A. Wrap dehiscence, B. Recurrent or persistent hiatal hernia with wrap, slippage, C. Misplaced or slipped wrap, and D. Herniation of entire wrap above the diaphragm. Positioning an operating table capable of steep reverse Trendelenburg position is required. Arms are tucked at the patient's sides but can be out 90 degrees and secured. Footboards on a split-leg table are mandatory, and procedural reverse Trendelenburg test is used for safety confirmation of positioning. Assume extensive mediastinal dissection will be warranted, and therefore, pleural compromise is a frequent occurrence. The sterile skin preparation must be wide enough on either flank in case tube thoracostomies are necessary from resultant pneumothorax. However, a red rubber catheter between 10 and 14 francs may be placed in a witnessed pleural defect intraabdominally, spanning the diaphragm to the hemithorax in question. This reduces the resultant pneumothorax and peak ventilatory pressures with the aid of lowering insufflation pressures as well as anesthesia-assisted ventilatory Valsalva. After Varese needle insufflation in either the supraumbilical or the left upper quadrant, trocar placement ensues. 5 trocars are used for the laparoscopic PH repair. After the liver retractor and ports are placed, the patient is positioned into steep reverse Trendelenburg and the dissection begins. After Varese needle insufflation in either the supraumbilical or the left upper quadrant, trocar placement ensues. 5 trocars are used for the laparoscopic PEH repair, figure 5b. After the liver retractor and ports are placed, the patient is positioned into steep reverse Trendelenburg and the dissection begins. Instrumentation. As aforementioned, there can be up to a 20% enterotomy rate during PEH repair, especially during redo operations. Therefore, extraordinary care is tantamount to establishing safe dissection planes, especially near the esophagus. Ultrasonic shears are the mainstay of dissection, harmonic ACE curved shears, Ethicon, Somerville, NJ, whereas when operating extremely close to organs, we advocate switching to laparoscopic scissors as well as blunt dissection to avoid thermal injury. Fig 3a-b esophagram. A. Radiography demonstrating a large PH with herniation of nearly the entire gastroclumen into the posterior mediastinum with mesaraxial volvulus. B. Slipped Nissen fundoplication with an intact wrap proximal to the diaphragm. Fig 4 CT of massive PH type 4 in which the entire transverse colon has herniated into the left hemithorax. Figure 5. Patient positioning, A, and trocar placement, B. After pneumoperitoneum is established, lines are drawn at the inferior edge of the costal margin diagonally up to an imaginary point above the xiphoid as a 0.4 trocar placement. 5 trocars are used for the laparoscopic PEH repair. 1. An 11 mm supraumbilical camera port, offset just to the left of the midline and 15 cm inferiorly. 2. A 12 mm left upper quadrant port, measured 12 cm along the parallel line to the left costal margin, for the surgeon's right hand. This port is placed 1 to 2 cm inferiorly to the 12 cm mark. 3. A 5 mm right upper quadrant trocar, measured 7 to 10 cm from the supraxiphoid point and 1 to 2 cm inferiorly, for the surgeon's left hand. This can be placed to the right of the falciform and then through the falciform. 4. An assistant's 5 mm left flank trocar is placed about a palm's width inferiorly and laterally from the 12 mm trocar. 5. Finally, a 5 mm port is placed and removed in the subxiphoid region for the Nathanson liver retractor. Similarly, a port can be placed at the right flank, symmetrically opposite from the assistant's port for a linear liver retractor, as supplies may vary per operating theatre. Reduction of the ANA to whatever extent possible. Reduce the contents of the mediastinum previously back into the abdominal cavity by use of both the primary surgeon's hands as well as the assistants with atraumatic graspers, Figure 6. Note that there may be various layers to the hiatal hernia sac, Figure 7. Fig 6 reduction of major viscera with blunt retraction back into the abdomen. The dotted lines indicate the plane of dissection about the hernia sac. Ig 7 layers of the PH sac. Note the interface between the visceral peritoneum and endothoracic fascia, sometimes fused to parietal pleura, should be the plane to establish during dissection. It is usually safe, once countertraction is well established and reduction of the entire pH is attained, to initiate dissection on the right cruise directly to the right of the esophagus, providing a starting point for anterior and posterior dissection. Anterior dissection occurs in a 180-degree fashion anteriorly and then to the left of the hiatus, just in a plane immediately deep to the peritoneum hernia sac. Any deeper and thermal injury or perforation might happen to the esophagus. If the hernia cannot be completely reduced intra-abdominally, then we advocate an approach from the left cruise, anteriorly 180 degrees to the right crus, Fig 8a-b, reasoning that the position of the unreduced pH and true dissection plane on the left can be more readily ascertained. The resultant anterior dissection can be seen in Fig 9. Posterior dissection ensues from the original starting point to the right of the esophagus to free the right crus posteriorly and deep, then as much as possible, to the left of the G-jade Fig 8a-b. Dissection from left to right, anteriorly, starting on the left cruise. Ultrasonic dissection takes place directly on the edge of the diaphragm at all times. Countertraction must be kept to prevent retraction off the hernia sac into the mediastinum. Before complete 360-degree dissection can take place, the short gastric vessels must be completely dissected, even if a previous procedure supposedly took place, as some surgeons selectively or incompletely perform short gastric takedown, Fig 10ac. This should be performed on the slow setting off the ultrasonic shears, as premature ligation might allow incompletely ligated vessels to retract into the gastrosplenic ligament uncontrollably. Although endoscopic surgical clips may help, it is more efficacious to regrasp the bleeding ligament and vessels for ultrasonic ligation. Occasionally, depending on their Fig 10ac short gastric vessel ligation. AB initial dissection begins at a level parallel to the distal splenic tip. C completion of the short gastric ligation. Note the exposure of the posterior stomach to complete this step. Posterior gastric atidement to complete the circular dissection, The surgeon's left hand and assistant splay the stomach to the anteromedial direction and omentum to the left. This reveals attachments posteriorly from the splenic vessels to the left gastroepiploic vessels. These can be taken also with ultrasonic dissection. After reduction of the posterior sac, figure 11, this completes the 360-degree mobilization, figure 12. A Penrose drain can encircle the GEJ for atraumatic retraction. Hernia sac excicon. If properly performed, the hernia sac can be removed en bloc by evidence of the mediastinal component of the hernia sac being contiguous with that of the anterior esophagus and fat pad, FIG 13AB, which may also need excision in order to properly perform the antireflux portion of the operation. If the hernia sac is large and will obstruct mediastinal dissection, excision of the sac is warranted. Start on the left cruise with traction on the hernia sac and use combinations of blunt dissection when near the esophageal body and ultrasonic dissection to remove the hernia sac when at a safer distance. Manipulation of tissues too far away from the esophagus may compromise the pleural cavity, and manipulation too close to the esophagus may incur thermal injury, often unrecognized at time of operation. Figure 14 demonstrates a close, but safe, distance of dissection to the esophagus. FIG 13AB excision of the hernia sac off the anterior esophagus. The sac is placed under countertraction and bivalved just to the left of the vagus nerve. FIG 14AB demonstration of proper range of proximity to the esophagus during ultrasonic dissection. A. View from left, near esophagus. B. View from right, approaching endothoracic fascia and pleura. Fundoplication TKDOWN. If there exists a previous fundoplication and preoperative testing demonstrates incompetence of the ANTIREFLUX procedure, the wrap is mandated to be taken down and redone. Extreme care should be implemented, as this is the step that carries the most risk of enterotomy either at the stomach or at the esophagus. Once completely dissected, inspection and reinspection of the taken down wrap should take place. Often, the gastric lumen may resemble the shiny planes between the fundus and esophageal body. Inadequate mediastinal dissection for esophageal length is encountered when the endothoracic fascia pleura is placed laterally, and the mediastinal esophagus is visualized in a 360-degree fashion up to the level of the carina or right atrium, figure 15. FIG 15 adequate mediastinal dissection as evidenced by 360-degree encirclement of the esophagus up to the level of the carina superiorly. Endothoracic fascia pleura bilaterally, and aorta posteriorly. Assessment of intra-abdominal esophageal LENG. The left cruise is now pulled from left to right, and without any bougie or orogastric tube in place. Crural CLS over a 42 FR bougie, the hiatus is sutured with the appropriate number of coated, braided non-absorbable suture, 0 T-Cron, Cavigian, Mansfield, Massachusetts. Spacing of sutures is approximately 1 cm apart from each other and is placed 1 cm back from the crural edges, FIG 16AB. Pledgets are used on the sutures with the exception of the last sutures needed to avoid pledget ingress into the esophagus. The quantity of sutures usually numbers 2 to 4, until there is a gap left between the esophagus and crura to easily interpose laparoscopic graspers between the closure. If the esophageal hiatus is gigantic, then anterior, in addition to posterior. Crural closure can be safely performed to prevent severe angulation of the esophagus at the newly reconstructed hiatus. Fig 16a-B crural closure with 0 T-cron pledged head sutures with 1 cm spacing, both from each suture and from the left and right crural edges. Depending on proximity to the esophagus, the last suture may be unpledgeted to avoid erosion. Fig 17a keyhole placement of mesh. B rectangular placement of mesh. Antireflux Paraesophageal. Either principles of fundoplication apply here, whether a complete, Nissen, Fig 18a-B, or partial, to pair, wrap is indicated. This completes the goal of reconstructing the angle of his and valvular mechanism of the LES. Refer to the corresponding chapters accordingly.